Welcome to Full PreFrontal, the show that exposes the mysteries of executive functions. This show is a collection of conversations about the role of the prefrontal cortex, which impacts your focus, planning, problem-solving, emotional balance, and independence. These conversations will introduce mental tools that will empower you to shift your mindset for a successful life. And now, here's your host, Sucheta Kamath.
All right, welcome back to Full PreFrontal, where we are exposing the mysteries of executive function. I am here again with our host, Sucheta Kamath. Good morning, Sucheta. As I said at the end of last week's episode, very much looking forward to our next conversation with Dr. Rappaport. Going to be great, some great stuff. But before we go there, it's been a couple weeks now, but I'm still enthralled with the story of this young Thai soccer team that got trapped in the cave and had to be dramatically rescued. And that's a great story, but gosh, what happens now? I mean, how do you thrive as a child? How do you thrive in spite of an adverse childhood experience?
Yes, thank you for mentioning that, because that was going to be my story today as we bring our guest Nancy Rappaport back again. So for those who don't know the story, I'm going to quickly summarize it. And sorry for those who already know. But, Paul was a 25-year-old Thai assistant soccer coach who was known to indulge the kids in exploration nearby and take them on excursions. On July 23rd, 2018, he took the wild boar teammates to the Tham Luang Nang Non caves in the Khun Nam Nang Non forest, which is part of northern Thailand. As the group ventured deeper into the nexus of the Thailand's longest cave on Saturday afternoon, a massive downpour caught them by surprise. And as the floodwater rushed through the tiny opening of the mouth of the cave, it forced the group to rush deeper into the caves to a secure and a drier spot, slightly at a higher elevation. At this point, the coach and the group of 12 boys, ages 11 to 16, found themselves trapped 3 miles inside the cave, away from the opening, cut off from the exit route completely because of the flooding, which didn't subside. And the head coach came along to look for the team when he got 20 frantic calls that evening from parents who reported that their children never came home. So he asked around and found out that the assistant coach had taken the kids on excursion. So he came at the entry to the forest, and he saw a bunch of bikes and backpacks lying around at the entrance of the park. And he immediately contacted the authorities. Soon after, a massive search and rescue operation, involving more than 1,000 people was launched by Thai officials, and they solicited help from divers and Navy SEALs from various countries, including Australia, China, Japan, UK, US. Luckily, on July 2nd, the 2 divers from United Kingdom found all 13 alive deep inside the caves. Apparently, the coach kept the kids engaged and fearless during this time, the trying times, and they appeared to be in good spirit without any panic. So the story for our podcast begins here, I feel. What was fascinating to me was when these divers found them, the coach handed these letters written by, he made every child write a letter to the parent while they were inside the cave. And he himself wrote a letter as well, and he passed on those to the divers who had to go back, and now they had to make arrangements because none of these children or the coach were, trained divers, or they did not have a way to know how to rescue them safe and alive. But the fascinating thing was 2 things. This was probably unimaginable childhood trauma, right? To be trapped inside a cave with your friends, but completely in the darkness, no food, water, nobody knows. You don't know whether people know, and nobody knows where exactly you are. And if this doesn't create a crisis, I don't know what will. But in this situation, these 12 boys were with the most amazing adult. Paul himself became an orphan at age 12, and he was sent to a monastery, and there he learned to meditate for 10 years. And after 10 years, he left the monastery and came back because his grandmother fell very ill. So he decided to take care of her. And as he was taking care of her, he would go and do some work at the monastery And then he also took up this job of becoming the assistant coach. But in the cave, he would meditate every day for 1 hour. And he made the children meditate and visualize. He gave all the food and little water that he had to the children. He never had any. And by the time they rescued them, he was the one with extreme, critical condition. But the most beautiful thing that I was about to say was about the letters. These letters, when they were read, one of the child, his name was Bill, which is Ekarat, but he went by Bill. He was a 14-year-old boy. He wrote, "Mom and Dad, don't worry that I'm missing for 2 weeks. I will help you at the shop very soon." And there was another kid called Pornchai, T was his nickname, who was a 16-year-old who wrote, "Mom, Dad, brother, and family, don't worry, I am happy." Those letters, as I read them, that just brought tears to my eyes. Here are these kids handling the worst adverse moment of their life, and they were with an adult who showed them the light and assured them and brought some sense of peace and optimism that gave them this outlook that I am happy. Can you imagine a child writing, "I'm happy"? Anyway, so this brings us to our discussion today, which is a part 2 of a conversation with Dr. Nancy Rappaport, who is the Associate Professor of Psychiatry at Harvard Medical School. In 2012, she received the American Academy of Child and Adolescent Psychiatry, a Psychiatrist Sidney Berman Award for the school-based study and treatment of learning disorders and mental illness. She also received Cambridge Health Alliance's Art of Healing Award in 2013. This award is given to one who transcends boundaries joyfully, embraces humanity, and profoundly inspires the healing of body and spirit. Dr. Rappaport's important works include The Behavior Code, a practical guide to understanding and teaching most challenging students, which she co-authored with behavioral analyst Jessica Minahan, and her memoir, In Her Wake, a child psychiatrist explores the mystery of her mother's suicide, which won an award from Boston Authors Club in 2010. Nancy advocated for support for struggling families. The Children's Storefront, a documentary of her work in Harlem, was nominated for an Oscar for Best Documentary in 1988. So I'm so delighted to have her because she will talk a little bit about how to handle children who exhibit challenging behaviors.
Well, I'm looking forward to the conversation, Sucheta. And yeah, I agree with you. It's amazing how these Thai kids got through that experience. I was freaking out, and I was thousands and thousands of miles away safe, and I don't think I handled it as well as they did. It was an amazing story. All right, well, this promises to be a very important conversation, and looking forward to it. Let's get to it. So here is Sucheta's second conversation with Dr. Nancy Rappaport.
Welcome back to the podcast, Nancy. I'm so delighted to have you. In your practice, what are the most common psychiatric disorders of childhood that you often diagnose and treat? And can you share with us in what ways they're important for an ordinary citizen, so to speak, to know about them?
As a child psychiatrist, probably the most common 3 disorders that I would encounter are attention deficit, trauma, and depression. So I think I should start with depression first, just because we do know that it's one of the leading causes of death is suicide in teenagers. And so I want people to know what they're looking for, and particularly when is someone just being a normal grumpy teenager and they, came by it honestly, and when is it a time to worry? And partly I'm going to go through a couple of things. One is the idea that function. So if you have a child who's having difficulty functioning, who has persistent poor mood, upset mood that lasts for at least 2 weeks, that really is, and then what are called neurovegetative symptoms. So that's when we were talking about the brain and the body, that not only is the depression in the mind, but it's coming out in symptoms of the body. So that's really important for parents not to miss. So one is and there's a mnemonic called SIGI caps, we can just go through them. Sleep is something which is really hard for parents to evaluate about when is it that the depression's gotten to the point where it's interfering with the child's sleep. First thing is getting electronics out of the room during the nighttime because kids are spending enormous amount of time on their electronics that may be interfering with their sleep. So you want to try to take that out of the differential. But if you have a child, and sometimes child sleep huge amounts. I mean, teenagers, they're like sleep monsters. They can go for 14 hours sleep. That's fine. If that's on a Friday night and they're going to get up at Saturday at 1, it might worry us. We don't want it to happen forever. But it is something when you're growing a foot between 14-year-olds old and 15-year-olds who probably do need time to sleep. But when you have a child who needs 3 alarms and is getting late to school for, and that's interfering in their ability to function at school, that's a signal to you. Is this something that might be part of difficulty with depression and emerging depression, particularly if you have a family history of depression, ADHD, substance abuse, because you want to get that treated and have a clinician help you tease out what's going on. Another piece is around appetite. Again, if you have an adolescent boy who starts to not want to eat, and that's frequently my tip-off for a depressed adolescent teenager, that's a signal to you that you want to think about it. And then with concentration, if you have a precipitous decline in academics, so it's different than the ADD kid, because the ADD kid, as we know, is diagnosed under 7 years old. It happens in 2 settings. They may have had trouble concentrating, but it's been a long-term problem. With depression, it's a cognitive slowing that happens. You feel like your brain feels like it's in a fog, and you can have students, children, and adolescents who start to have a pretty big dip in decline. Of course, you always want to think about substance abuse and whether that's going on, but that's another place where you want to think about it. The other one is guilt. So if you have children will sometimes, when they start to get depressed, they'll spend an enormous amount of time ruminating, going over and over a small thing that happened and perseverating on it. And that's a piece. And then, of course, the biggest one is around when you have a suicidal child. And that always needs an evaluation. Sometimes I see it more in when you have a completed suicide, it's always the tip of the iceberg. And sometimes when I read in completed suicide reports, I was just reading one in the Washington Post of a young boy who was 11 years old. And the mother will say, well, he said he wanted to kill himself 2 years ago, but I didn't think he really meant it. And we always want to take it seriously when a child is talking about feeling so desperate that they want to kill themselves, and letting them know, is this what you really mean, that you want to kill yourself? Have you thought about ways that you want to do it? Let's make sure to get you some help, and never dismiss it. So there's the depression one. What I would say about trauma, what's important about trauma is, unfortunately, how often it happens. There's a study called the ACE study, the Adverse Childhood Event Study, which was done back in the 90s on 17,000 adults in California, middle-income folks. And what was so prevalent was over 25% of adults had some kind of significant trauma happen in their life, in their childhood. And why I bring that up is sometimes people think trauma only happens in poor neighborhoods, but we have mental illness, we have divorce, we have suicide, we have lots of things that happen to kids regardless of what economic background they're from. And that's an important piece for us to keep track of, because with trauma, it does impact your brain. The places that it impacts your brain are, especially between 0 and 5 years old, are the amygdala, the hippocampus, and the cortex. And the amygdala is your fight or flight response in your brain. It's the smoke detector in your brain. And the hippocampus is your ability to do memory. And your cortex, your prefrontal cortex, is your executive functioning area. So you can have children who have executive functioning difficulty because they have attention deficit disorder, or because they have attention deficit disorder and trauma, or they just have trauma. So that's really important to have that in our differential when we have a child who has trouble concentrating. And one of the reasons why it's important is I actually think for really bad ADD that probably is semi-traumatic for kids because they're trying so hard, but they don't always able to perform as well as they do. But the other piece of it is that with trauma, you treat it differently. You definitely teach co-regulation skills, but kids who've had trauma have trouble trusting adults and may have trouble settling to learn. So the relationship is incredibly important. And also, oftentimes children with trauma have trouble being vulnerable. And there's a saying, if you live with sharks, don't bleed. So the part with trauma is that children and families need to figure out how to build a story about it, how to build an understanding of what happened. Because oftentimes with trauma, it's of course important what happens in terms of what happened in terms of trauma. Were you kidnapped? Was it a divorce? Was it domestic violence? But what's most important in terms of resiliency for children is their ability to tell a story, their ability to make sense of it. That's what allows them to go forward. So those are the three places that I would say I see the most is attention deficit disorder, trauma, and depression.
I am really, really moved by the way you are explaining this. And particularly, I think this is going to add great amount of value to people who work with this in the context of education or private, treatment, or if these are parents who are dealing with. But I don't think people view or you're helping them understand trauma in a different sense. So and this just, lots and lots of cases come to my mind. I have worked with somebody who the mother herself of this child with Asperger's who was going through significant problems in school, not understanding social nuances, but the modeling was not there at home as much as I would like to see. But the mother was a survivor of a childhood abduction. And she was missing for a month or two or something significant. I have seen parents having, very, very traumatic breakups, and where the father has run the mother's car into a tree and in front of the children, or when the mother was inside the house on a lockdown, when the father was circling the house, shouting and screaming at 1 a.m., and the children could hear it and they were protecting the mother. But once the event was over, nobody ever talked about it, or that was never addressed. Yeah. They never saw a psychologist or a psychiatrist. I mean, I can just go on, but that was not even the focal point of raising children or dealing with executive dysfunction that I deal with. It just is something really for people to think about. I don't think if you have a history of ADHD, and generally people's case history questions include any events of distress that have happened to you that have complicated the issues for you. So I really appreciate you bringing that framework into this discussion. Do you have any comment or thought about that?
Well, I think what you give in terms of the student who was on the spectrum and the mother who'd had her own trauma history is the idea of ghosts in the nursery, and that the mother coming into a situation, let's just pretend that this kid on the spectrum both had executive functioning difficulties and was aggressive. You could imagine how quickly the mother could feel ashamed, that because she carries her own sense of fear and that the world isn't safe. So she may come into an interaction with the school loaded for bear when she's really feeling vulnerable. And so it's a plea for us to remember that when we have parents who are coming at us sometimes in ways that can seem aggressive, that they may be feeling incredibly protective and vulnerable, and that we want on some level to help reassure them that we have their best interests in mind.
Absolutely. You have co-authored a brilliant book called Behavior Code, which you mentioned a while ago, a practical guide to understanding and teaching the most challenging student. I personally believe that it should be part of every teacher, educator, and parents read before the school reopens, I guess, or gets in session. Can you, and you have in that book laid out a systematic approach to cracking the code of patterns in behavior that difficult children exhibit and that cause them to be this way. Can you share that framework with us and provide us some proven strategies that educators can use if they see this behavior in the classroom even?
First, what is sort of the underlying principles that I think are important that we outline in the behavior code? And so this idea, and we called it the behavior code because we wanted people to be like detectives. So the concept that behavior is communication. So getting curious about what is the child trying to communicate. The other concept is that the only behavior we control is our own. So that idea of being calm, clear, and consistent, and also being aware of our nonverbal behavior. So that, because think about it, 60% of our communication is nonverbal. So that's a concept that's so important. Then the idea that behavior can be changed, which when you're struggling with a child that has very challenging behavior, you can often feel stuck. And there's a researcher, Seligman, who talks about learned optimism. And that's a way for when you get depressed as a provider, it's because you think something's permanent and it can't be changed. So if you can look for small changes, that's incredibly important. And then what we did was we called it a FAIR plan. And that's partly because educators always have acronyms, but also because many times educators can feel like making accommodations for a kid that's dysregulated isn't fair. And we were like, okay, well, then we're going to just call it the FAIR plan. And I wrote it with a behavioral analyst. And partly I did that because right now in schools, a lot of schools come to a grinding halt when a child's escalated and they say, well, we need to get an FBA, a functional behavioral assessment. How many of you as parents have heard that? And I felt like parents don't really know what that means. And then the behavioral analyst, if they're may come back with all these graphs. And so I wanted parents and teachers to understand, well, what does a functional behavioral assessment mean? And to give them the language that behavioral analysts use. And so F stands for the function of the behavior. And there's a psychologist, Mark Durand, who has like a grocery list of how to think about the function of behavior. And he has 4 different behaviors that he outlines. One is sensory. So it looks good, feels good, tastes good. So that may be a child that's on the spectrum who likes to touch soft things or takes a pencil and puts it near to their eye. The tangible is I want it and I want it now. So that might be somebody who really has a hard time waiting in line going to the cafeteria. And then attention, which we talked about in part 1, but it's the idea that negative attention is fast, efficient, and predictable. And what we want to do, whether we're parents or educators, is ramp up the positive attention. And there's a researcher, Pianta, who talks about banking and the idea that sometimes you can get into these negative cycles and you have to be really conscious of spending positive time. And he says you only need 10 minutes a day and you can turn that trajectory around. And sometimes teachers will say, well, I don't have 10 minutes. How long does it take to evacuate a classroom? About an hour. So finding 10 minutes a day for some of your really tough kids can be really helpful. And we have a suggestion of putting pennies in your pocket. So if you move your penny from one, if you have 3 pennies in your pocket and you're teaching for the day, you move the penny to the opposite side of the pocket to let you know that you've given 3 positive comments for feedback. And then, so we have sensory,
I love that.
Tangible, attention, and then escape. So escape is the fight or flight response. And that goes back to what we talked about in part 1, where unfortunately, many times, although there's no evidence that suspensions or detentions works, we will send kids home or out of the classroom when they've done an offense. And the problem with that is that you end up reinforcing the behavior. So trying to figure out, and then we spend some time talking about antecedents, behaviors, and consequences, trying to figure out what the antecedents are, what are the things going on before the crisis, before the behavior, and then figuring out how to implement that. And many times, just giving you a cheat sheet, this is the Reader's Digest of the Behavior Code, y'all. So many times the patterns you see are typical antecedents, typical things that happened before where kids struggle is unstructured times, transitions, writing demands, social demands, and novel events. And some parents might say, well, that just about covers the whole day. Yes, but it means also that if you have that kind of cheat sheet, you can start thinking, okay, think about it. When you go to a restaurant and you sit down, the waitress comes over and brings crayons for the kids so they won't escalate and they have something to do. And it's having that kind of future thinking where you walk through a day and you think, what are the things that we need to do to scaffold our irritable child who needs help with transitions? And then hopefully over time you begin to help them think about what it is that they need. So F was for function, A is for accommodation. So there are a whole slew of practical accommodations that can be made in the classroom. Again, this is written in a way. I've spent 23 years working in schools, 23 years sitting in individual ed plans. And many times a parent comes into that setting and there's 8 school folks in a room and 2 parents. And if they're lucky, maybe they have an educational advocate. If they have an educational advocate, they're way ahead of the game. But otherwise, it's a quote unquote team meeting. But parents don't always have the ammunition of what it is that they need for their, in our book, we're talking about kids with oppositional behavior, kids with anxious behavior, kids with withdrawn behavior, and kids with sexualized behavior. They may not have concrete suggestions for what needs to happen. And when we talk about I, which is the interaction, so we have function, accommodation, interaction, and response, many times we know as parents that there are certain teachers that know how to work well with our child. And then it gets lost. You have this exquisite teacher who understands about transitions, who understands about unstructured time, who understands how to make a demand and then move back, who doesn't ask for things in a question mark, but knows how to be playful, knows how, and your child does relatively well, and then they get to the next classroom and it evaporates. Why don't we document that in individual ed plans? What are the interaction strategies that we know help our child function? Flexibility, making a demand, giving a small amount of time before the child has to do it, not getting into power struggles. So that's the other piece that we encourage. So there you have it.
This is Thank you so much. And, I will be making a link to all these resources that you're talking about. But I think this book particularly I love is there are, templates of how to kind of, it's a guidebook. So it has all the tools packaged. So it's not just an abstract idea, but you have given a workable, implementable plan for people to follow. So I really appreciate the time you two have taken to build this resource for all of us. As we come to the end, I wanted to see if you could talk about a little bit about technology, and technology and addiction particularly. Are there any behavioral trends that you're seeing that parents are wired and they are raising wired children? And that's creating a new set of challenges in parents knowing how to put limits, but more importantly, how to model how they put limits, which I don't see them do often. How do you see all that?
So, all of us living right now, I was very lucky. My kids are all in their 20s. So I was fortunate enough not to have iPhones available to me from when my kids were 0 to 14. If I had them available, because I have them available now, I know I would have been more distracted because you have instant access to your email and to the internet, and it is so seductive. So I would say for all of us, we need to think about times when we turn the phones off and we have cell phone no time, we're not on our cell phones. And, some people, I'm working on it. I can't say I've done it yet, but some people actually have, a 24-hour period, say a Friday night to Sunday morning. They don't respond to emails or they don't use their phone. Sometimes you can separate it. So if you're going to be having, I think one thing that's just completely insanity right now is that families are allowing iPhones at the table. So I've been in families where everybody's on their iPhone and they're eating. And if you look at the studies about what protects families in terms of the single, one of the most important things is having family dinner. But I don't think the studies looked at having family dinners with the iPhone, because that shouldn't be invited to the table. And so that would be a huge, just small thing that we would want to do. And then the other piece I would say is not to overgeneralize, because sometimes some kids are socializing with the internet and have different things that you're doing. So we don't want to group everything together. If you have a child, the way I would think about internet addiction is having a sense of what your child is watching, because we know adolescent boys, 60% of adolescent boys are getting onto porn sites, and that is not where I want my child being introduced to sex. So having some sense of where your children are going when they get onto the internet, and then having some open discussions about what are some of the dangers with chat rooms or making connections, and being honest about some of those things. So some of it is also getting informed about that and looking at resources that help to make you feel confident that you can ask questions.
Wow. Well, Nancy, this has been a smashing interview. That's all I can say. You've given me so many things to think about. I am, again, so excited to have you, and I'm grateful for your time. We will have all kinds of information on our website, and we will be linking to your fabulous website that explains a lot of your breadth of works. So thank you once again for being on this podcast and explaining and taking the time to connect with our listeners.
I'm so happy to have the opportunity, and I'm happy to have your listeners reach out to me if I can be useful.
All right, so that was Dr. Nancy Rappaport. Sucheta, your second conversation with Nancy. Another impactful conversation. Gosh, where to start? A lot of things to think about here. I guess where I want you to lead us off with is a discussion around common psychiatric disorders of childhood.
Yeah, so Todd, I've been in practice for the last 20 years, and I find this a very tricky balance that parents, teachers, educators, specialists like me are trying to strive for, that they have a child who seems to be having difficulty in the classroom. The teachers feel there is something wrong. This is not a typical behavior, but it's also not a behavior that can be ignored. The parents have sought some help, including seeking help of a psychiatrist, but they're not most comfortable with a label, or they're not comfortable sharing that label with the teachers. And then they bring in somebody like me, who is an expert, who deals with having to help people develop strategic thinking and strategic processes. And I feel more information that we provide, better it is. So we have a very, very different relationship with psychiatric disorders. If a child has cough and cold, or a child has, let's say, a lump on his head, we will take him to a doctor and we will share that information with the teachers. But when it comes to psychiatric challenges, somehow there's a great reservation and fear. So I just wanted to start off by thinking about what Nancy's talking about, that, just emotions are integral part of developing healthy adjustment to human condition. And, emotional regulation is integral to executive function skills, and it's on a spectrum. Some are really rooted, and some children are very equipped to handle the pressures and setbacks, and some are not. And then some, on the other hand, have genuine disposition to a psychiatric disorder and have a severe unmanageable disorder that needs treatment. So we have to be very cautious of that. For starters, Nancy talked about three main types of psychiatric diagnoses that are most impactful in the classroom and that she sees herself dealing with. They included ADHD, trauma, and depression. And I'm glad that she talked about depression. Adolescent brain is susceptible to depression simply because of the exponential growth that it's undergoing and the hormones, and having to adjust to changing body, changing relationships, and changing responsibilities. So the interesting thing about all these factors that she discussed, that there is a persistent theme which impacts the children and teens. One is the ability to concentrate and think complex. Second is ability to adapt and adjust, or in other words, to take good decisions and solve problems. And third is to ability to socialize, which often, feeling of worthiness, feeling of liked versus disliked, and eventually even getting isolated for not feeling a sense of belonging. The reason I'm mentioning that these emotional states and psychiatric disorders have tremendous impact on a child's ability to succeed and self-regulate. And executive function is your capacity to adjust
with and without challenges in your life. And so I feel it's a really important conversation for us to have if we want to really understand executive function. What's interesting about depression, particularly, that it's worth reviewing the major depressive criteria that Nancy talked about, the acronym, SIG CAPS that she was talking about. It stands for S being sleep, which can be increased or decreased. If it's decreased, it's often early morning awakening. And I will attach the website that I got this from so that people can read about it. I is for interest, which is diminished interest in, life's activities and events. G is for guilt or worthlessness. Thought rumination is very, very common. E is for energy. Again, feeling fatigued very easily, decreased energy, dragging around, those kinds of things. C is for concentration, which is difficulty making decisions. In other words, particularly in my work, there's something called cognitive slowing, walking through molasses type of feeling. A is for appetite. As you can imagine, a child without appetite is a teenager particularly without appetite is a really alarming sign, right? A psychomotor activity, which is decreased or increased psychomotor activity, which is also can be concerning. And last but not the least is the suicidal ideation. So these are the criteria she was talking about. In order to be diagnosed with depression, one must have at least 5 of these symptoms present, and these symptoms must last for 2 weeks. So as I mentioned in this point that I'm making, that emotional adjustment is a challenge for everybody. And persistence of these challenging persistence is the key. These symptoms just don't let out, and they are not bound by a situational setback. They are beyond a situational setback. Then we should show great concern. So psychiatrists like Nancy are called to investigate and support and diagnose and treat. Nancy, urges families to weigh the risk and rewards for introducing medication. And I just think it's a complex matter, and we should not take it lightly. I'm so glad to see a movement and openness towards psychiatric disorder, but it's still, the person can go through enormous shame when it comes to suffering from emotional setback.
Well, we led off the conversation talking about the dramatic rescue of the Thai children's soccer team and talk about an adverse childhood event. Go a little deeper on what is the true impact of something like that.
Yeah, so I think there's one, there may be, ADHD and depression. Maybe there's a familial history. There is a, genetic trend for you to be more likely to develop ADHD and depression. But childhood adversity or adverse childhood experience, which is also known as ACE, is not it's a situational challenge. As you saw, it was, in fact, these 12 boys went on a hike. There was one boy who finished the practice and his mother came to pick him up, so he went home. So he was spared from this adverse childhood experience compared to these 12 boys. But so there's it's no brainer that both positive and negative childhood experiences impact child's wholesome development and lifelong trajectory. The research shows that there's a robust link between adverse childhood experiences and risky health behaviors, chronic health conditions, low life potential, and even early death. I mean, these are serious matters. On the CDC's website, I was reading about this, that it says that these experiences have tremendous impact on future violence, victimization, and perpetration, and lifelong health and opportunity. So adverse childhood experiences can be prevented, and we as a community need to create an environment that is safe for all children to have a decent growing up experience. Just a quick note about having lasting impact. There was a chart which I will also attach on our website, but that the number of adverse effects that a child experiences between the ages of 0 to 18 has direct correlation to the number of outcome data. And so, the health, which is obesity, diabetes, depression, suicide attempts, STDs, heart disease, cancer, stroke, those can be adversely impacted. Behaviors such as smoking, alcoholism, and drug use is impacted by these negative life activities. And life potential, which is graduation rate, academic achievement, lost time at work, from work, all these are risks that are generated by negative, life experiences. And let's say if you have more than 5 life, setbacks in your childhood, then you can assume that you will have almost 40 plus negative outcomes. So that's a serious stuff that we're talking about.
Yeah, no doubt about that. So can you share an approach to actually managing problematic behaviors?
Well, glad to, and I'm basically summarizing what Nancy talked about. But children with psychosocial emotional adjustment challenges can be handful, and their problems don't go away because someone is compassionate with them. The patience exuded by an adult and compassionate outlook of community communicates a certain mindset, which is very, very essential. Don't get me wrong. What mindset is it communicating? That you are welcome. Things are going to be okay, and you're safe to struggle here, and you won't be left alone without any assistance. That's what that attitude and mindset is communicating to the child. But beyond that, Nancy's approach, which she has gone in depth in her behavior code book, that she talks about 3 vital principles. Number 1 is behavior is a form of communication, so pay attention. 2, misbehavior is a symptom of something a lot more than meets the eye. And 3rd, only behavior we can control is our own. So in order to manage bad behavior, you should manage your own bad behaviors, so to speak. and I think the bad behaviors here I'm talking about is, how we feel angry when somebody's angry at us. We feel, I don't deserve this anger from you. So anger meets anger. So imagine if you're a teacher and a child is throwing a tantrum as is disrespectful, your first response cannot be of compassion. It will be of anger. And if you're angry, then you are not going to help manage those emotions. So it's really important to think of that. So the most important thing to remember is that mild or alarming changes in classroom behaviors are possibly stemming from depression, trauma, or other behavioral disorders. So it is going to impact child's relationship with his peers. We have a special obligation to attend to the needs of the children who have endured trauma. We need to be more, tender and loving in case of those children who are going through something significant. A child's ability to read emotional cues may be impaired or distorted. They may be misinterpreting the baseline social signals. They may be hypersensitive to them, or they may be blasé to it. So the message in her book, The Behavior Code, is that the student's behavior is a symptom and an attempt at communication. So we need to be keeping our eyes open for that.
Okay, so you've referenced this book, The Behavior Code, a great read from Dr. Rappaport. Any other golden tips from this book that you want to share with us?
Yes, certainly. The child's experiences of failure is normal and inevitable. However, not every child responds to a failure with optimistic enthusiasm. Some in fact exhibit unrestrained, sensational, unacceptable behaviors, which then become the greater source of misunderstanding. During the moments of stress-filled interactions with such children who are either anxious, withdrawn, sulky, confrontational, or even defiant, we must pause and take hold of our own emotions. Nancy, in her book, Behavior Code, proposes something called a FAIR plan, which outlines the steps teachers can take to unscramble students' challenging behaviors and initiate a plan that works. So the FAIR is an acronym, which is FAIR. F stands for understanding the function or purpose of that behavior. A stands for problem solving and seeing what accommodation might work. I stands for envisioning interactional strategies, and R starts for carving out responses. So Nancy and her co-author, Jessica Minahan, using the FAIR plan, say that they can elicit more flexibility and patience from teachers as they get the teachers to shift their focus from having the child to move towards less unacceptable behaviors and get to the bottom of these problems. In one of the articles that I read, Nancy wrote, by adopting the FAIR plan, teachers can discover that inappropriate behavior is malleable and temporary. I thought that was a very profound statement that she makes. And she believes that the student can be taught how to thrive using this approach.
Yeah, no doubt about that. Fascinating stuff. So, gosh, about out of time, Sucheta. Before I let you go, any closing thoughts that you want to share?
Yes, absolutely. I probably sound like a broken record, but safe and still, talking about children, I'm just so compassionate and just champion of children. Safe and stable environments and nurturing and meaningful relationship is the key ingredient to ensuring that all children can reach their full potential. The beauty is that the children who grow up to be healthy and productive citizens, in turn, have a shot at building stronger and safer families and, in fact, communities on their own. And they can create a much well-adjusted next generation. So it is up to us as a neighborhood, community, society, and culture to promote the types of relationships and environments that can help. A difficult child is not a teacher's problem. A child going through difficulty is telling us a lot about his needs, and we need to reconsider that as an urgent matter and as a health crisis or even a human crisis.
All right. Well, as we close, Sucheta, let me just say this. If I had to be trapped in a Thai cave, I would choose to have you at my side to help me through it.
You're too kind.
All right. Well, that's it for today. On behalf of our host, Sucheta Kamath, and all of us at Cerebral Matters, thank you for listening today, and we look forward to seeing you again right here next week on Full PreFrontal.
Thank you for listening to Full PreFrontal, exposing the mysteries of executive functions. To contact our host, Sucheta Kamath, and learn more about her work on improving executive functions, visit her website at cerebralmatters.com. That's cerebralmatters.com. Tune in next week for the next informative episode of Full PreFrontal.